Normal interictal EEG does not exclude epilepsy. We have many requests. Please do EEG to exclude epilepsy. This is not possible. And for example, a common reason for first seizure, it's sometimes confused with syncope. EEG is rarely useful in this situation. Only if a bad history is taken do we get confused. Now, what about epilepsy classification? Now, in childhood, you all know that there are a number of common epilepsy syndromes: the idiopathic or genetic generalized epilepsies, the epileptic encephalopathies, and the benign focal epilepsies of childhood. Now, in these groups, EEG can guide us. For the genetic generalized epilepsies, we see a healthy child. EEG background is beautiful, it's normal, and occasional generalized epileptiform abnormalities are seen. Sometimes photic sensitivity, and as you all know, with childhood absence epilepsy, hyperventilation is a useful diagnostic test, even in the clinic without EEG. And you are all used to seeing beautiful EEGs like this. This is a 6-year-old with childhood absence epilepsy, hyperventilating, beautiful EEG, then 3 hertz spike and wave. We can make a very definite diagnosis clinically and with the help of EEG. You also may know, and this montage I will use for almost all of the EEGs I show you: longitudinal bipolar, left temporal, left parasagittal, midline in the middle, right parasagittal, and right temporal. You can see muscle artifact over left temporal region and rhythmic posterior delta, occipital intermittent rhythmic delta activity. This is more common in childhood absence epilepsy, but is not a specific finding and may be seen in normal children as well. Sometimes the EEG that we see guides us to the clinical diagnosis in genetic generalized epilepsy. This 6-year-old girl is having absence seizures, but you can see she has bursts of polyspike and wave. This is not typical of childhood absence epilepsy. Maybe this little girl has juvenile absence epilepsy, or when she gets older, juvenile myoclonic epilepsy. So sometimes the EEG findings will guide us to the kind of generalized epilepsy. One very important fact is that for the genetic generalized epilepsies, all syndromes, very commonly when the child starts to get drowsy, we see fragmentary focal abnormalities. This does not mean the child has focal epilepsy. This is typical in normal drowsiness and sleep. Same montage, left at the top, midline in the middle, right at the bottom, and on this drowsy EEG, we see polyspikes on the right, polyspikes on the left, and also in the midline. This does not mean multifocal epilepsy. This is typical of generalized epilepsy. Also, we need to be careful that normal variants can fool us. Here are 3 examples of 6 hertz spike and wave, a normal variant of drowsiness, and we do not want to misinterpret this as epileptiform. Photoparoxysmal responses are common in the generalized epilepsies, less common with focal epilepsy. If there are associated eyelid or limb jerks, this is a very important marker of photosensitive epilepsy. And this is one of my patients. You can see the purple line at the bottom, Photic stimulation with eyes closed, no abnormality. Photic stimulation with eyes opening, no abnormality. Photic stimulation and then eyes closed, generalized photoparoxysmal response. Opening and then closing the eyes during photic stimulation is the most powerful way of showing photoparoxysmal response. And if there's a clinical feature, and I show you the video here, flash, no problem, eyes closed, opens eyes, still no problem, closes eyes, myoclonic jerks. A very useful way for photosensitive epilepsy detection. But I should mention that photosensitive epilepsy is not a single epilepsy syndrome. Juvenile myoclonic epilepsy commonly has photic sensitivity, 1 in 3 patients, but some very severe epilepsies, including Dravet syndrome and other progressive myoclonic epilepsies, have photic sensitivity as well. Now, what about epileptic encephalopathies? These are children and adults who very commonly do not have normal intellect. They have important intellectual and behavioral disabilities. They have a slow background. They do not have a normal background. And as you know, we may see generalized slow sharpened wave, generalized fast activity, and sometimes other findings, especially in epileptic encephalopathy with focal causes like tuberous sclerosis. In the very young, as you know, hypsarrhythmia is typical. High voltage, crazy, frightening, polyspikes, multifocal. As the infant becomes older into adult life, more typically with epileptic encephalopathy, we see slow, sharp, and wave. Sometimes the sharp waves can look a little bit triphasic. This is a 7-year-old with Lennox-Gastaut syndrome. And these people with epileptic encephalopathy commonly have this other feature on EEG, a burst of generalized low amplitude beta activity, sometimes called generalized paroxysmal fast. This is often associated with tonic seizures, but remember, bilateral tonic seizures are not always generalized in onset. This 54-year-old man has had bad epilepsy since early childhood with severe intellectual handicap. Let's look at his clinical seizure. And hopefully it'll work, but if it doesn't, I'll describe it to you. So video doesn't work. What happens is he has a seizure and relax. What did his EEG show? His EEG showed generalized paroxysmal fast. He also had slow, sharpened wave, but on imaging, he has right focal cortical dysplasia of the frontal lobe. Here's another child. Hopefully the video will work here. Video is always a problem. No problem. Well, I demonstrate. This little girl has epileptic spasms, maybe 20, 30 a day, for 18 months old, frequent, yep, didn't work. So not a problem. Anyway, she has epileptic spasms. It doesn't matter. We'll just move on. Oh, there we go. Oh, it's working. Oh, is it working? Videos are always a problem. So we'll move on. That's okay. Now, her EEG shows generalized hypsarrhythmia. During her epileptic spasms, she has generalized electrodecrement with paroxysmal fast, but her imaging shows left temporal DNET. She has this removed, no more seizures, normal. And so the message is that if you see generalized tonic seizures, these may be of focal origin at any age, commonly in adults, frontal and posterior extratemporal epilepsy, but in infants and preschool children, even temporal lobe epilepsy may present as an epileptic encephalopathy, and so we need to be very careful. Now, what about focal epilepsy? Now, if we are looking for focal epileptiform abnormalities, we need to do two things always. We recognize focal epileptiform spikes because they are not artifact and they are not a normal variant. Many artifacts, many normal variants. They disrupt the background, the spikes, often slowing in the same region, and of course have an electrical field, unlike artifact. My teacher, Donald Klaus, he reminds me so often in EEG, forget what your mother taught you. Not all sharp things are dangerous. Normal variants are not dangerous. Artifact is not dangerous. And to gain experience in this analysis, computers will not help you, but having a skilled mentor and teacher will help best. For example, in the benign focal epilepsies of childhood, common childhood epilepsy syndrome, we see a normal child who has a very abnormal EEG. And as you all know, the EEG shows typical centrotemporal spikes. Here on the left centrotemporal spikes with the red arrows, and on the right, the same. These characteristically have a triphasic morphology, a small aftercoming slow wave, and often they have a dipole. This is the same page on transverse, front at the top, occiput at the back, central in the middle. Here is the negativity of the centrotemporal spike, and in the midline, central and frontal, the positivity. And as you know, these children, when they're asleep, very commonly we see lots and lots of spikes. There are continuous trains of epileptiform activity with sleep. And we have that thing in the middle, which I don't know what it is. Oh, great. Thank you. In adults with focal epilepsy, for example, mesial temporal sclerosis, these are interesting spikes. These are propagated to the neocortex. They are not, we're not seeing them just coming from the hippocampus. And this is a short montage, and I can, now I don't have any control. Oh yeah, here we go. This is a right temporal spike. Let's look at a little bit more closely. It has many phases. Firstly, a small positive phase, then the big negative phase, then another positive phase, another negative phase. Multiple phases are very typical of these focal temporal spikes in temporal lobe epilepsy. Often anterior to mid-temporal, sometimes a small dipole in the midline, a slight positivity. Compared to neocortical epilepsy, not coming from mesial temporal structures, where the field is much bigger. Here is a longitudinal bipolar montage, left temporal, left parasagittal, midline, right temporal, right parasagittal, parasagittal temporal. Here are our right temporal sharp waves. CZ is not involved, so good reference. Let's look at on reference. We see that the sharp waves are maximal at F8, A2, T4. We have a good electrical field. Sometimes, if you see spikes over temporal region with big field, we must think maybe it's not coming from the temporal lobe. The orbitofrontal cortex, the frontal and parietal opercula, the insular, and even the occipital lobe can produce what seems to be temporal spikes. These tend to have a wider field. And here's an example. Same montage, left temporal, left parasagittal, midline, right parasagittal, right temporal, lots of muscle artifact. And then we have this, sharp and slow wave. It is coming from the left, but is temporal, frontal, central, and even midline. This is from somebody who has gliosis of the frontal and temporal lobes. If we do CZ reference, this is not going to be good because it's active. And here's the same page, CZ reference. It looks like the spike is on the right side. It is not. This is because of contaminated reference. Other than temporal lobe, other neocortical focal epilepsies can be quite difficult. Frontal lobe epilepsy, particularly mesial or inferior frontal lobe epilepsy, very often has widespread or bilateral spikes, maybe look generalized. Parietal lobe epilepsy, the same. And occipital lobe epilepsy, only 10% of occipital lobe epilepsy have discrete occipital spikes. Most is widespread or even generalized. So we need to be aware sometimes epileptiform abnormalities that look more generalized may be coming from focal epilepsy, but spreading. And here's a patient with left frontal gliosis from old injury, left midline parasagittal. You can see his symmetrical bilateral anterior spike wave act. Here's a 20-year-old with bottom of the sulcus cortical dysplasia. And sometimes when it's close to the surface, we can see this particular phenomenon, rhythmic, fast electrographic discharge, sometimes called red discharges, which are very commonly seen in focal cortical dysplasia, as long as the dysplasia is discrete and close to the surface. So EEG can help us classify some generalized and focal epilepsies very well. But how important? Well, there have been 3 studies in our region which show that compared to history, the EEG changes clinical diagnosis in only small minority of patients, somewhere between 2 and 15% only. So history is number 1. Now, what about EEG for predicting seizure recurrence? You see someone has first seizure. Will I have another seizure, doctor? Well, from our own data, green line shows first unprovoked seizure, EEG normal. Blue line shows first unprovoked seizure, EEG epileptiform abnormalities, and you can see epileptiform abnormalities more likely to have second seizure. And the difference from our data is about an 18% increase at 2 years. Notably though, remote symptomatic, the red line, these are people who have had old head injury, old stroke, old tumor surgery. EEG does not predict their recurrence at all. Interesting. And in most of these patients, the EEG did not alter whether you started treatment or not. What about EEG in assessing epilepsy treatment? In routine EEG, it's a routine follow-up. EEG is not so important. I ask my patient, are you feeling good? Yes. Any seizures? No. Make sure they're telling the truth. Grandma, any seizures? No. I'm happy. I'm not interested in the EEG. There's a very poor association between interictal EEG and seizure frequency. It's not a useful marker for epilepsy management, with a few exceptions. Juvenile absence epilepsy transitions to my adult clinic, wants to drive, has brief absences they do not aware of, 10-second bursts of spike wave, I'm not so happy they're going to drive. And so this can be helpful. As you know, in tuberous sclerosis, epileptiform abnormalities will predict a need for seizure treatment even before clinical seizures are obvious. Sometimes West syndrome, it can be helpful in, uh, uh, in following the patient, but even then clinical progress is more important. What about EEG for stopping treatment? We all know that we need minimum of 2 years seizure-free before we consider stopping treatment. Now, but however, EEG is not the most important factor. It's the duration of seizure freedom. If somebody has focal lesion in adults, this is not good for stopping seizures. If the patient has juvenile myoclonic epilepsy, not so good for stopping medicine. Taking more than one drug. And in a recent paper from last year, there was no association with EEG findings either before, during, or at the end of anti-seizure medicine withdrawal with recurrent seizures. So decisions need to be individualized, and EEG is far less important than other clinical factors. Now, EEG in acute hospital is very, very powerful. We can tell if somebody is having unrecognized seizures, perhaps herpes encephalitis. We can tell if somebody is having psychogenic events or a severe metabolic or toxic cause. And this is very helpful in the comatose patient, as we all know. However, its usefulness depends on the quality of the interpretation. This lady has 78, she has renal failure, she has multifocal twitching myoclonus. Clinical team from renal unit says, oh, we think she might be in status epilepticus. Okay, we do an EEG. Oh, it looks very spiky, maybe 2 or 3 per second. Let's look a little bit closer. These are typical sharp phase lagging triphasic waves. This is not epileptiform abnormality. This is toxic encephalopathy. And the cause for this lady with renal failure is she was given cefepime. She gets cefepime in toxicity. Cefepime stops, she gets better. Pre-surgical evaluation we will not cover, but as you know, EEG is an essential part of the investigations. Interictal and sometimes ictal EEG, sometimes invasive recording. But again, you have to know what you're doing to make a good report. So to summarize, EEG roles in epilepsy. EEG is essential in the minority of patients. If I go to a small island, what will I take to diagnose epilepsy? Will I take an EEG machine? No. I'll take an interpreter. I wish I could speak Mandarin. I will want to communicate with the family and the person. And maybe I will take some anti-seizure medicines, and I will start these without EEG, without even imaging, because it's a clinical diagnosis. For classification, yes, it can help us, but only in a minority of patients. And for follow-up, with only a few exceptions, it's not so important. However, in acutely sick patients, this can be very helpful, preventing people being misdiagnosed as having seizures and being poisoned with too much seizure medicine. And pre-surgical evaluation is very important. Now, epilepsy is misdiagnosed about 1 in 4 people, mainly because of inadequate history, but also, almost importantly, because of misinterpretation of EEG. And this is why we're here together. People are reading EEGs who are not adequately trained, and this is dangerous for patients because we misinterpret, we make wrong diagnosis. So the solutions, and this is why we're here together, old and new friends, is adequate training, not to have sudden simple course, 2 days, now I'm an expert, but just to introduce, and then standards of training, and this is where the CEPA EEG certification examination is so important. created by Lim Shi Wei. Here he is, very good archer as well. And with this examination is a beginning to indicate that at least we're doing something right. And ongoing mentoring, most important. Do I see an EEG 1 week? I think, oh, this is crazy. I do not know what's happening. I ring a friend, call for help. Calling for help is a strength. It's not a weakness. None of us know everything. You stop learning, you die. So, finally, to best help our patients, firstly, we must listen to them and their family. We also must study EEG carefully with a mentor. And it's a little bit like learning a musical instrument. When you start playing the guitar or violin, it's not so good. But then gradually, if you become more skilled, hardship is replaced by enjoyment. And the knowledge that our patients, we serve them better by being skilled in reading EEG, just like being skilled in taking a history. And this is the beach near my home. So
Thanks, John. Your speech as always inspire and make us to have a courage to learn more from EG and patients. I think we have time, maybe 1 or 2 questions from the audience. 现场我们有一点点时间，现场有没有当场想问 ？OK。
我们主持啊，一定要先问哈，那个省得冷场。John, can I ask you a question? Always many students ask me. For example, you have just shown EEG that is left frontal focal cortical dysplasia with police bias and spice over the left frontal frontal polar region, and then spread to the right side. So what's the exact mechanism? Is it volume conduction? Or through the corpus callosum nerve conduction? What's the exact mechanism? Can we differentiate it?
So with the frontal lobe epilepsy in particular, the parietal lobe epilepsy too, the interhemispheric connections are very strong. And so propagation is very fast. And so my own view is that, and sometimes if you stretch EEG out, you can see a small latency difference, and this will prove propagation. However, if they're very close electrodes, for example, FP1 and FP2, inevitably there's also volume conduction, inevitably. And so we're dealing with a combination of both. And in the case of temporal lobe epilepsy, it's much more easy because you will see a latency shift with propagation, but not so easy with similarly O1 and O2. There's always volume conduction between these two. So I think it's a very difficult.
Yeah. If it is caused by volume conduction, can we still call it a secondary bilateral synchrony?
No, I think volume conduction is simply volume conduction. A good example is when you see EEG and you see lots of ECG artifact. I know patient has big neck, big thick neck, because now big volume conductor from the heart up to the head. This is volume conduction, and volume conduction is a part of our lives. And this happens all of the time in EEG as well.
我们神经上面的所有的，你们最简单一翻到脑波上面 ，FP1、FP2 眼睛一动，上面 FP1、FP2 不是正电就负电吗？那眼睛跟 FP1、FP2 中间没有任何神经相连，对不对？这是物理传导，物理传导是瞬间上去的，这是电的传导，瞬间上去，不是神经传导，所以这叫 volume conduction 啊。所以脑子里面任何一个地方记录到，当然也有神经传导，但绝大部分都是 volume conduction。像心脏的电传上去，心脏跟耳朵没有任何相连嘛，对不对？一定是 volume conduction。volume conduction 是物理传导，是瞬间。 马上的哈，所以那个没有时间差。那神经传导，如果把纸张如果够敏感的话，会看到左右有时候会有时间差，你会看到时间会有一个顺序，那是神经传导比较慢嘛。
The next speaker，下一个是Professor Ernest Soverwell，也是 from Australia。那他另外一个身份呢是Global Outbreak Outstretch Task Force 的 Chair。所以呢，基本上你们现在碰到的这几位 Master 全部都在 ASEPA Teaching Course 里面占着不可撼动的地位哦。那前一堂我们听的是怎么去使用 EEG 哈，然后下一堂呢，他可能要讲一点点比较 basic technical basis of the EEG， 所以呢这两堂加起来呢，可能更 echo 了刚才关老师问的问题，就是当我们在看一个 EEG 的时候，除了你看到你眼睛看到了之后，你能不能想到它背后的原因是什么？我想接下来 Ernie 的演讲会告诉我们更多哦。Ernie, please.
Thank you very much. It's nice to be here. I have tried to come to Taipei twice before. The first time I think was when Topamax was being launched, so that's a long time ago. But then I think they found somebody better to talk, so I didn't come. And then a couple of years ago, I was going to come to talk about EEG, but then COVID happened. So it's nice to be here eventually. I'm sorry I can't stay longer, and I have to come back when the weather is better and can stay a longer time. And I also should just mention I've known Professor Jingjiang Tsai for many years. I think I first met him in 1995. So look, this talk is basic. So I hope that it's not too simple for you. I'm sure you know a lot of this already, and I hope you don't feel that I'm talking down to you. But I have a fairly simple mind, and I need to understand these things very simply. So I'm going to try and share that with you. So let's start. What is EEG? So EEG is just a way of displaying changes in voltage that occur on the scalp, and those are generated by postsynaptic potentials in the cortex. And they tend to occur rhythmically. And the rhythmicity is generated by interactions between the cortex and the thalamus predominantly. Now, each neuron only produces a tiny amount of electrical current, electrical potential. And so if we're going to record something at the scalp, we need to have many neurons doing the same thing at the same time. So, which means they have to be synchronized. So if we look at this wave, if each individual person doesn't make much movement, the only reason we can see the wave is because they are synchronized. They are all doing the same thing at the same time. The third dimension is spatial distribution over the surface of the head. So EEG measures voltage changes over time and space. We have some arbitrary frequency bands, and these are measured as cycles per second or hertz. So we have alpha, beta, theta, and delta. So if we have 8 waves in a second, it's 8 hertz. If we have 18, it's 18 hertz. Just a couple of terms. Amplitude is measured in microvolts. Sensitivity or gain is is the like the volume control on a radio. The channel refers to the display of voltage fluctuations between a pair of electrodes, and I'll talk many times about the fact that each line that you see is the result of what's happening at 2 electrodes, not 1 electrode. And montage is just a collection of channels that are displayed some kind of sequence that makes sense. Now, differential amplifiers are the type of amplifiers that are used in EEG, and they're called differential because they record differences. They record the potential difference or voltage between 2 points on the head, 2 electrodes. They do not measure the absolute value. And it's, if you think about measuring, it's like measuring the waves on the top of the ocean. It doesn't matter how deep the water is. It doesn't matter if it's high tide or low tide. If you're just measuring the height of the waves, that's what you're measuring. Now, this is very useful because there is this thing called common mode rejection. And what that just means is that because differential amplifiers record only the differences between the inputs, if there's some great big thing that's affecting both inputs, affecting the whole of the head, we're not really interested in that. And the amplifier won't see it. The amplifier will reject it because the amplifier is only looking at differences. And here's an analogy. If we look at the 2 butterflies at the top, one of the butterflies is heavier than the other one, and so the balance tilts. The 2 elephants are much heavier than the butterflies, but they weigh exactly the same. And so the balance shows no difference. If the butterflies then move on top of the elephants, then the balance shifts. So even though it's the tiny little signal, the tiny little difference between the 2, but the amplifier, or the balance in this case, will measure that difference. It will show that difference, even though we've got something much bigger that's happening at both. But because it's the same at both, it's common to both, it's not recorded. And that can be very useful and extremely useful in EEG. We're not talking weight, we're talking electrical potential. It's useful to record localized activity, and it gets rid of some artifacts. So for example, if you have, I'm not sure if it's in 50 hertz or 60 hertz in Taiwan, if you have the electrical mains interference, that can be a big problem when you're trying to record EEG. If that affects all the electrodes over the head to the same degree, which it usually does, then when you use your amplifier to measure the difference between the 2, you won't see that 50 hertz. It'll be subtracted out. It can be a little bit misleading because you can have brain activity which is widespread. And similarly, that may not be seen by the recording G. Now, I've mentioned that these things record differences. Remember that you can look at differences in 2 ways. So if you say one person is more tall than another person, that's the same as saying they're less short. Or if you're saying someone is more short, that's the same as they're saying they're less tall, more light, less heavy, whatever. And in the case of EEG, where we're talking about electrode pairs, saying that one electrode is more positive than another electrode is the same as saying it's less negative, and vice versa. So if you look at these 2 people here, if we look at this photograph, we can see the difference in height, but we don't know, maybe they're both tall people and she's extremely tall. Maybe they're both short people and he's extremely short. Maybe they're just average height, she's taller than him. We can't say, because all we can see here is the difference. And similarly with EEG, so the amplifier can't tell the difference between something negative happening at one electrode or something positive happening at the other electrode. The difference will be the same, and I'll give you some examples of that. So these differential amplifiers are really just voltmeters, just like this thing here at the bottom. That's what EEG amplifiers are. But of course, they're much more sensitive than this. And they produce an output, and that output is graphed against time. And there is a convention. So this is just entirely arbitrary. I don't know who decided this, which is that if the first input 1 of the amplifier, you can just call these input 1, input 2. Sometimes you'll see in books grid 1 and grid 2. It's the same thing. Each amplifier has 2 electrodes. If the first one is more negative than the second one, then the line goes up. And you normally, these amplifiers are often drawn like this, with a triangle and the 2 electrodes going into it and then the output. So from what we've said before, saying you only have to remember one of these. You only have to remember lead 1 more negative is up. Lead 1 negative up. If you remember that, you can figure out the rest of them. Because lead 1 more negative up is the same as saying lead 2 more positive, because it gives you the same difference. And then the opposite of that is lead 1 being more positive. So the line goes down. Lead 2 being more negative is the same as lead 1 being more positive, so it's going to move in the same direction. That difference will be the same. And as we said, the machine can't tell the difference. So let's just run through a few examples. We'll leave that one at the top to remind you. If we go to the, should use the mouse, I guess. If we go to this first example, which one is more negative, lead 1 or lead 2? Well, lead 2 is more negative, so it goes down. Which one is more negative here? Well, more negative is the same as less positive. So which one is more negative? It's going to be lead 2. And so again, we're going to have this exactly the same recording. Our EEG machine will record exactly the same waveform, even though what we're looking at is quite different. How about this one? Which one is more negative? Well, again, it's lead 1, just like the one up the top, but we've got 2 negative here, so it's even more negative, and so the pen goes up even further. So the size of the movement of the line depends on the size of the difference between the 2 electrodes. Double the difference, double the size of the line, double the amplitude. Now, in this one, we've got something negative happening at both electrodes. So which one is more negative? Well, it's lead 1. So again, the line goes up. And this one, they're both negative again, but this time they're both negative to the same degree. The EEG amplifier records the difference. What's the difference? Nothing. There's no difference. So we get a flat line. So a flat line in an EEG does not mean that there is nothing happening. It just means that whatever is happening is the same at the 2 electrodes that you're looking at, that your one EEG channel is representing. Remember, every EEG channel represents the difference between 2 electrodes. And similarly, there may be something positive happening equally at both electrodes, no difference, flat line. We've seen this one already. How about this one? We've got something positive happening at both electrodes, but it's even more positive at electrode 2. So if we want to use our lead 1 negative up, which one is more negative? Well, more negative is the same as less positive. So that's 1. So it's going to go up again. So we've got 2 extremely different situations here that give you exactly the same EEG output. Now let's just talk about referential recording. So each amplifier, we've said, requires 2 inputs, and we can't tell whether a voltage fluctuation is due to a change in input 1 or input 2. Now it would be really helpful, wouldn't it, if we could just have one of those electrodes, some neutral point that wasn't changed by anything that's happening in the brain, and then we could just subtract what's happening at the other electrode from that one. And that is unfortunately not technically possible, but we can make there are some attempts to do that. And if we could do that, it'd be really useful. We could just see where things were over the head, and we wouldn't have to worry about things being cancelled. And so let's look at this in theory anyway. So here's a referential recording. So we've got 4 electrodes here on the head, and we've got another electrode here, which is also on the head. This is our neutral reference point. And let's say that there's something negative, a negative spike happening at electrode B, and nothing happening at the other electrodes. So let's connect up our amplifiers like this, so that input 2 of every amplifier is connected to the reference. So all of these amplifiers use the same input 2, that's the reference. And if we do our lead 1 negative up exercise, the difference between input 1 and input 2 of the first amplifier is nothing. The difference here, which one is more negative? Input 1, so it goes up. The next one, any difference? No difference, flat line, flat line. So in a referential recording, we can see this deflection up in the electrode that's affected. Now that's one way of connecting up electrodes. So you put some reference point, you plug that into input 2 of every amplifier. The other way of doing it is this, where you connect input 2 of each electrode is connected to input 2 of one amplifier and then input 1 of the next amplifier. So you get this sort of head to tail arrangement that's called a bipolar chain. Now this is the same as what we just saw. We saw a negative spike at this electrode B, but now we've got our amplifiers connected differently. Let's see what happens this time. In our first amplifier, which one is more negative, input 1 or input 2? Input 2, so the line goes down. The next one, this time, it's in input 1 of the next amplifier. So input 1's more negative, so the pen goes in the opposite direction, goes up. And down here, there's no difference. So this is what's called phase reversal. It's where you see these, you see a waveform moving in opposite directions in 2 adjacent channels. One channel and the next channel, you see the waves moving in opposite directions. And when that happens, it means that what you're seeing is coming from the electrode that is shared by the 2 amplifiers. In this case, electrode B. And so, so it's important that this is not an abnormality. It's just a way of localizing things. It's just a way of telling where a wave is coming from, a wave or spike or a normal phenomenon. So there are plenty of normal things that show phase reversal. Vertex sharp waves of sleep will show a phase reversal. Depending on the montage, posts that you have over your occipital regions during drowsiness and sleep will show a phase reversal. Lots of normal things show phase reversal. So phase reversal is just a term to describe this, this way of localizing something. And the reason that we use it is because your eye, your brain, your brain, not the patient's brain, tends to notice things if they're going in opposite directions like that. You're more likely to see it. And that's the reason that this arrangement of electrodes is used. Now, quite often, when an event occurs, like an epileptiform spike, it may involve more than one electrode to the same amount, same degree. So the maximum is not just at one electrode, it may be at two. So let's do our lead 1 negative up exercise. First one, lead 2 is more negative, so it goes down. The next one, what's the difference? Well, there's no difference. So we get a flat line. The next one, input 1's more negative, so the pen goes up. So we get this appearance. We get a flat line with the adjacent leads pointing towards each other. And this is quite common. You see this quite commonly. For example, the F7 and T3 electrodes may be equally involved in somebody with medial temporal lobe epilepsy, for example. And you'll see a flat line with these two spikes pointing towards them. And that does not mean, a flat line does not mean nothing's happening. In fact, in this case, that's where the maximum activity is. Just to mention interelectrode distance, the further apart that you have electrodes on the head, the greater the amplitude. Once you get beyond about 10 centimeters, it's not important. And so if we want to compare amplitudes on different sides of the heads, it would be a good idea that we have our electrodes, if we're going to compare electrode pairs on the two sides, that those electrode pairs are equally spaced. So there is a system to try and do that called the 10-20 system of electrode placement. And it aims to have the distance between electrodes to be equal. It's called 10-20 because it's based on these measurements that are either 10% or 20%. And basically the technician makes these measurements where they intersect. You place electrodes with odd numbers on the left, even numbers on the right. A is for ear, Z is for 0. These are sometimes called P5 and P rather than T, these posterior temporal electrodes. And here we are. And as John pointed out, even though an electrode may be overlying a particular part of the brain, doesn't necessarily mean that the activity that you're seeing is coming from there. And that's particularly true of this F7 and F8 electrodes. F stands for frontal, but in fact, the activity that you see there is often generated from the temporal lobe. Now, just to mention field, this refers to the spatial distribution of voltage over the scalp. And here's another analogy. If you look at these people sitting around a fire, it's hottest. These people are the hottest, and the ones on the outer part are the coldest. But if we were to look at the difference between two people in the same row, it would be the same. And the same kind of thing happens with EEG. So the field, we're talking about voltage here. It has a maximum involving 1 or 2 electrodes, but the neighboring electrodes around that will also be affected. And so if you have a negative spike at 1 or 2 electrodes, the other ones around it will also be made not as negative as those maximum ones, but still more negative than the rest of the head. And we can draw these isopotential lines, same as we had those isothermic lines with people sitting around the fire, we can have isopotential lines. So in this case, we have a maximum, let's say, we can call this a This could be a negative spike, an epileptiform spike at C3, but it's also making CZ, F3, T3, and P3. They're also more negative than the rest of the head. And so if we do a bipolar recording like this, where we run electrodes longitudinally through this focus, this electrical focus, then this is what we'll see. We can just work this out. So we've got the maximum at C3, maximum negativity, but we've also got some negativity at F3 and P3. So we can say that there is a field that is involving F3 and P3, but the maximum is at C3. And if we go through our lead 1 negative up exercise, first amplifier, lead 2 is more negative, so it goes down. The next one, lead 2 is more negative, so they're both negative, but lead 2 is even more negative, so it still goes down. Next one, which one's more negative in this amplifier? Well, they're both negative, but lead 1 is even more negative, so it goes up. We get a phase reversal. And then the next one, which one's more negative here? Lead 1, so it goes up. So we get this appearance. We get our phase reversal here in the middle, but we also have deflections on either side of that pointing in the same direction. And again, this is really common to see this in clinical EEG. Whereas, and that was bipolar recording, that was a bipolar chain where we've got each electrode being input 2 of one lead and input, being input 1, start again. Where you have each electrode being input 2 of one amplifier and at the same time input 1 of the next amplifier. So that's a bipolar chain. But if we use referential recording like this, FP1, and again going through this same sequence, in this case, we don't get a phase reversal. Instead, we localize on the basis of amplitude. So the maximum is determined by the biggest wave. And we can work through these things. In the interest of time, I think, am I over time? I've lost track of time. You are? Okay, we've got a little bit more to do. There are various different references that can be used. And then there's this thing called source derivation, where what you do here is input 1 of the amplifier is the electrode that you're interested in. Input 2 is the average of the neighboring electrodes. Just a word about having a comfortable patient. This is actually really important if you want to get good EEG. You need to reduce EMG artifact and movement artifact as much as possible, which can be very challenging in some situations, but it's very important. The electrodes should be comfortable. Patients should be preferably lying down, not sitting upright. It should be a quiet, dark environment, and you have to have a technician who's skillful to achieve that. Now, reformatting montages, I'll just mention quickly. The idea of this is that you can change the montage after the recording has finished. And this is one of the main advantages of digital EEG. You couldn't do this with paper EEG. So just to give you an analogy, if we have 2 balloons here and we wanted to measure the difference in height between them, there's 2 ways we could do that. One is we just get on a ladder and record the difference in height, A minus B. The other way we could do it is we could measure the difference from the ground in both of them and subtract that from each other, and we would get the same thing. So we can do this with EEG as well. We can either record directly the difference between 2 electrodes, like we're doing on the right here, FP1 to F3, or we record each one of them separately to a reference and then just subtract that from each other. And computers are very good at simple arithmetic like that. So they can subtract numbers from each other. Now, when it comes to reformatting montages, here's an example. Let's suppose we use that method of climbing up on the ladder, and we recorded the difference in height between these two balloons and between these two balloons, and then the balloons went away, and we then thought, you know, what I'm really interested in is the difference between B and C. Well, if you recorded it this way, there's no way you can do that. However, if you had used the other method where you just recorded the height from the ground of each of the individuals, then you can. You can subtract any one from any other one. And again, that's what EEG does. So it records all of the individual electrodes against a reference point. Doesn't matter where that reference point is on the head. And then when you want to find the difference between any two electrodes, you just subtract those numbers from each other. And so you end up with this. So what you actually record, what the machine stores on its hard disk, is the differences between each electrode and the reference. And then when you ask it to display a channel, it does that by subtracting those numbers from each other. And just to prove to you that this works, I was once on a very long flight. When you live in Australia, you go on many very long flights. And so here's a second of digital EEG. And what I did was measured the you can read those figures that the machine stores, and what it does, machines you can set it up how you like, but this example is recorded at 200 samples per second. So 200 times per second, the EEG machine measures the difference between each electrode and the reference point. In this case, we looked at P4 and the reference, and these were the numbers. And this here is an Excel spreadsheet. So I just manually typed the numbers in. As I said, it was a very long flight. So I typed all these numbers in here and then did it for the O2 electrode against the reference as well, and then got Excel. So again, this is an Excel spreadsheet. This is not an EEG machine. The Excel spreadsheet just subtracted those numbers from each other and put them on a graph, a simple graph, and did that 200 times. And there's 1 second of EEG. And then compressed that down, just squashed it down, and put it on top of the EEG, and it works. So that is how EEG machines work. I wasn't sure until I did that. Yeah, so now just a quick word, just to finish, filters. Filters are really important. They can be very helpful, but they can also cause problems and lead you astray. So the idea of a filter is to reduce wave frequencies that we're not interested in because they're making it harder to see what we are interested in, or they're just irrelevant. And you can have low frequency filters that reduce low frequencies, or high frequencies. You can have a notch filter that reduces a very narrow frequency range, like the electrical interference that you have, and you can have a band pass, which is the opposite to that. The relevant frequencies, what really matters for EEG, is between 1 and 70 hertz. So this is for routine clinical EEG. There are slower and higher frequencies that are sometimes relevant, but for routine clinical EEG, 1 to 70. If you look at the number on an EEG machine, when it says that something is a 1 hertz filter, that doesn't mean that it gets rid of everything slower than 1 hertz. It means that it reduces activity at that frequency, usually by about 30%. And then if you, but frequencies beyond that, a frequency slower than 1 hertz will be attenuated even more. But it's important to realize that it doesn't eliminate that frequency. They can be useful to attenuate slow artifacts like slow eye movements and sweat artifact. High frequency filters are used primarily to attenuate EMG artifact, but the problem is it can make EMG look like cerebral activity, so you have to be very careful, and the notch filter for interference. The problems they cause is they can conceal poor technique. So it may be that an electrode has fallen off the head, nobody's noticed, and the EEG still looks okay because filters have got rid of those waves that would have told you, those frequencies would have told you that there was a major problem. I mentioned making EMG look like brain waves. It can conceal pathological activity. So there might be slowing there, and if you turn up the low frequency filter too much, you won't see it. 50 hertz artifact is a very good indication that there's a problem with an electrode. And if you have the filter on, you may not see it, and so you may not realize there's a problem with the electrode. And some artifacts are useful, like slow eye movements in drowsiness, for example. So filters can be extremely useful if they're used intelligently, but not arbitrarily. So sunglasses are a filter, and sunglasses can make it easier to read if you're out in the sun, but they don't make it easier to see when you're in the dark. So remember, each EEG channel displays the difference between 2 points, and remember, lead one negative up. Thank you.
Thank you, Ernie. It's not always so simple. Yes. No, it's not. It's not simple. So every day we struggle with technical basis. 现场有没有人对于这个？因为每天在看脑波的时候，你可能整天在挣扎 polarity 啊、negative 啊、positive 啊，你要用什么 filter 啦？当然蒙太奇等会关老师可能还会再提。但是呢，现在你在用这些脑波的时候，其实不是一打开，你们看到这些脑波，就会知道你大概都要做一些后置动作，所以你必须要了解我为什么要去换这个蒙太奇，为什么要去用这个 filter。那这个 polarity 到底代表什么意思？然后在什么蒙太奇里面，哪种的 polarity 可能代表 hint 你是什么意思？但现在我们蒙太奇虽然是 1020 system 出来的，但是现在还有一些 modified 的蒙太奇哈。那我想可能在 clinical practice 上面，也许在座的各位也有很资深的前辈，然后还有一些这个新人。就是当你们在正式开始看 EEG 的时候，你们对于使用这些 filter 啦，然后甚至在蒙太奇上面，有没有什么特别的问题？我觉得很难得，Ernie 在这里，大家有没有想要问的？
如果大家都没有问的，我就把Ernie 的 summary 一下。Ernie can summary your talk。那个有没有发现他里面花了很多的时间一直在讲那个正负电的关系？所有都是这样，因为我也带过你们，就很多人就用数字来减，这个是最基本的。两相减之后得到什么数字？脑波只在于脑波的学问就在于画那个 differential amplifier， 那个一个不带电的减掉一个负电，就得到什么正电，对不对？就是这个东西，完全都在这边。脑波完全不管怎么 reformating， 你用各种蒙太奇看都是这样。蒙太奇就是不管你怎么换，你就看一只猪，你就可以从正面看、侧面看、下面看、屁股看，你就到最后就知道一只猪，这是 reformating。但是一切所有的精华都在于 differential amplify， 就那个三角形了。所以那个一定要会画0减掉-20得到正20，对不对？-10减掉-5得到什么-5，是不是？这个一定要会画。你只要会画这个，所有的蒙太奇你都会画了。那个还有什么问题要问？所以今天我觉得精华在这。他告诉你，我知道我去医学院看过，这个永远是 lying 比 sitting 好不要做 sitting 的。有没有哪个医院做 sitting？ 坐在那边做脑波的，不要做 sitting。那第二个不要用 cap， 要用 disc 要贴的OK， 10-20 system 还是最专门，那个以后当然如果你们更精进，还有可以更贴一些additional 的 electrode， 当然是 OK 的。
Yeah. Any other question? No. Thanks, Annie. 现在我们大概有一点时间，我们要 coffee break 哈。那等会还有2堂master 的 class 哦，所以大家现在，我现在看一下，现在的时间是10:06，请大家回到10:30回到位置上，好不好？大家可以先去用点点心，喝点热茶、咖啡。